we can see the viewer, the DICOM viewer and
Okay.
abdominal
So
viewer.
basically, can Akash and Latikesh hear me?
Yes, sir.
Yes. So I'll be showing you mostly very simple cases, which you will get to see in your routine day-to-day work, and maybe one or two odd in the exams. And the reason I'm showing you directly from the DICOM viewer is so that if you want me to do any MIPS, any reformats, axial coronal sagittal, please go ahead and let me know. We'll make this interactive as much as possible. And if you want to see an arterial phase or a venous phase or something else, you can let me know. And I'll put it up on the screen for you. Will that work?
Yes, sir. Okay, sir.
Right? Okay. So shall we begin?
Yes, sir.
Okay. So this, I think, was a young lady who came to us with history of severe abdominal pain, and there was no other history, right? And let me see, I'm losing some of my controls to the Zoom. Just 1 second. Let me see how this is going to work. Because my chat box has gone up on the top. Okay. Bring it down. Okay. And we have 198 participants that I can see. So I would encourage you all to please put in your replies or your opinions anywhere in the chat box. And of course, if you feel that the diagnosis does not match with the diagnosis I've given, I'll welcome a discussion on that. Right. So this was a young female. All right. So these are the venous images. Total venous phase, easiest. I thought
We can't see the scan.
you can't see the scan.
Yes, sir. Please share your screen.
Okay, let me go back. All right. Can you see it now?
Yes, sir.
Okay. Sharing? Is it? Can you see it now?
Yes, we
Yes,
can
yes.
see it.
All right. So this is a young female. These are the images. This patient came with acute abdominal pain, suspected mesenteric ischemia. We were asked to scan. Ultrasound was not showing anything much except some amount of fluid in the pelvis. So I'm going to go up now. Okay. If you want to see the coronals, let me know. Right. So straight off the bat, do you see anything abnormal?
Multiple collaterals can be seen.
Okay.
Ascites also is there. Moderate.
All right.
Mesenteric haziness is there.
Great. Do you think this is ascites or do you think this is altered fluid?
Yes.
Is this like water or is this proteinaceous fluid or pus or blood? What do you think?
Peripheral enhancement is there. So altered fluid.
Yeah, that is there. And the other thing you can do is, if you're not sure, you check it with the urine. All right. If it is brighter than the urine, then there is altered fluid. Okay. So other than that, why do you think there are multiple collaterals? So once you see multiple collaterals, the next job is, of course, to figure out there must be something blocked somewhere, right?
Yes.
So collaterals are formed as a response to an obstruction which they are trying to bypass. Or
Yes.
yeah. So do you see anything? Okay, I'll give you a hint.
Yes.
We'll try and trace the duodenum. Okay. So this is the stomach.
Yes.
This is the duodenum. We are going to trace this. Okay, and then it goes up. It goes up here. Can you see that?
Yes. Yes.
Then it turns. Can you see it?
Yes.
right? The duodenum actually, instead of crossing over like this, it goes up and it turns like this.
Duodenal volvulus.
Okay, all right. So midgut volvulus associated with malrotation, you would say.
Yes.
So then, did you look for the position of the colon?
Yes.
So shall we try and trace the colon?
Yes, sir.
So this is the sigmoid.
Yes.
You're going to go up. All right, descending. You're going up, coming down, and here it crosses. Can you see it crossing?
Yes.
Does it cross in front of the mesentery or behind the mesentery?
Behind.
Behind the
Behind them.
mesentery. So it's crossing behind the mesentery, right?
Yes.
Is that normal in a malrotation? Is there only one type of malrotation? Okay, let's trace it further. Here it goes. Here it goes. You can see it going up. You can see it turning, and it comes somewhere here. All right. Do you see anything else near that? Do you see this?
Yes.
So where is the cecum, do you think? I just showed you where it is ending. It is ending somewhere here, right?
Yes.
The IC junction is somewhere here. This is
Yes.
the cecum, the base of the cecum. This one. Can you
Yes.
see anything happening there? See this structure?
Appendix.
Yeah. And can you see this collection?
Yes, sir.
So when normally in a malrotation, in a normal rotation, what happens is the duodenum crosses behind the mesentery and the transverse colon is in front. In this case, what is happening? The transverse colon is behind the mesentery and the duodenum is in front. This is known as what? This is actually what is known as a reverse rotation. It's a really very rare anomaly. One of the, I think, the rarest kind of. So you can have non-rotation, you can have different rotations, partial rotation, and you can have reverse rotations. Okay, there are different types of. There is a spectrum of the type of bowel malrotations that you can have. In the classic non-rotation, which we have, where all the large bowel is on the left and the small bowel is on the right, generally the mesenteric attachment is quite long and you don't get a volvulus. In this case, you have two things. Okay, you have a reverse rotation with a volvulus, which is compressed the superior mesenteric vein, and then the appendix is abnormally placed.
Yes.
You have a ruptured appendix in a cecum, all right, with reverse rotation.
Reverse rotation.
All right.
Yes.
Good. All right.
Yes, sir.
Are we happy with that?
Yes, sir.
Shall we move on to the next case? So
Yes.
in every case, right, you have to not have satisfaction of search. In every case, you should, whatever your diagnosis is, two or three things you should always look for in the abdomen. One is where is the DJ flexure and where is the IC junction. As a matter of routine, even when you're doing liver, even when you're doing pancreas, it should just be part of your checklist that I always want to see where is my IC junction and where is my DJ flexure. Okay, and you can actually get a lot of, you pick up a lot of stuff that way. All right, that was a little tough, I guess, especially as a first case. Let's look at this one. So now whose turn is it?
Identification.
Okay, so what we'll do for you is we'll put this in the coronals and we'll put this in the axials. So acute abdomen is acute, right? You don't get clean scans. You get all these scans which you have to sort out sometimes at night where the surgeon is standing next to you and trying to decide whether to wake up the anesthetist or not.
Yes.
Right. So here we have a postpartum woman. She had a history of surgery earlier, but she had no records with her. She just delivered a few days back. Then she continued to have acute pain abdomen. These are her axial images. Okay. So I'll tell you to make life easier that she had a hepaticojejunostomy because she had calculi in the CBD, etc. So
Yes.
this is not what we are looking for. We are trying to figure out why she got so much pain. Can't be the calculi. We've already done a hepaticojejunostomy. So these are the left hepatic ducts, right hepatic ducts. They go into this structure. I'm tracing this structure down. Okay. I'm going down. We have something like this over here. God knows what's happening there. Maybe going down further. There is some loculated fluid. Here are your coronal images. Let's come back from the ducts. Right duct, left duct. They go into this structure. Right.
Yes.
So what are we looking at? That's the postpartum uterus. We'll ignore that.
Yes. ISBR.
Yes, that's correct.
ISBR is there. Yeah. Choledocholitis is there.
Yes.
GB.
GB,
Can it be GB?
GB
Yeah.
won't be there. HJ is done, no?
Okay. Yeah. Right. Gross ascites is there.
Yes. What is this?
CBD.
CBD is the.
Post.
So when you have HJ, you will have a bowel loop anastomosed, right?
Okay.
Tripota. So the right and left duct should be anastomosed to what?
Jejunum.
Yes. Right. So they should be anastomosed to jejunum. So should you be seeing at the porta? You should be seeing
Jejunum.
jejunum. Absolutely right. So what we are expecting this to be is jejunum, right?
Right.
Normally, when you have good HJ, do you see dilatation of the ducts?
No.
So in any case, when you are looking at an obstructed duct in a patient with HJ, either there is a stricture of the HJ, right?
Okay.
Or
Right.
the loop into which the duct is going is dilated or obstructed, okay? So now let's try and, so everything is about trying to see how things go in a sequential manner, okay? So
Yeah.
these are the ducts. This is a tubular cystic structure. It goes like this. Then it turns this way. Then it goes here. Then it goes here. Okay. Then it goes here. Then something is happening here. And then it goes here. So what do you think this is?
Jejunal obstruction.
Yes.
Jejunal loops are dilated.
Yes. Absolutely right. Go on.
Probably due to a stricture at the anastomotic site.
Okay. So if you have a stricture at the anastomotic site, why would the jejunal loop be dilated distally?
Okay, right.
This loop is dilated distally. So when you give contrast, you see this loop?
Yes. It's not dilated.
Can you see this loop? Is there a difference?
Yes.
Can you see this loop? Is there a difference?
Yes, sir.
What is the difference?
The walls are thinned out and even the loops are dilated.
Correct. And do you see good enhancement of the walls?
No, sir.
I also showed you this, remember? Can you see what this is? What is this?
It's collection puff, it can be puff causing pneumoperitoneum.
Okay. So let's look at our findings now on the coronal images. Okay. And these are the right duct, left duct. This is your jejunum, which as you said is not enhancing. I'm tracing this jejunum. Can you see the jejunum next to it? It's so different. Over here, you can't even see. Can you even make out the inferior wall of this loop?
No, sir.
You can't, right? And then it goes up, then it goes here, and then what is happening here? Can you see? This is one loop. This is one loop. Can you see what is happening here?
Stricture is there.
Two loops are coming together, right?
Yes, yes.
So
Additions.
what the concept you must know, the surgical concept is that there is a transverse mesocolon here. Okay,
Yes,
there is a small bowel mesentery here in the inframesocolic compartment.
yes, sir.
When you want to anastomose a loop to the stomach or to the liver, what will you have to do? You will have to come up either ahead of the colon anteriorly, which is called an anticolic anastomosis, or you will have to make a hole in the transverse mesocolon, pull up the loop and anastomose it at the porta, which is called a retrocolic
Colic
anastomosis.
anastomia.
In this patient, what has happened is that the space which they made for the anastomosis, multiple loops have herniated through into the supramesocolic compartment, these ones, as a
Yes,
result of which,
internal.
the venous supply has been damaged at this area because this is the hole and too many things are going through it. So the venous supply is not coming back. So you have got a gangrene of the loop, which is and obstruction of the loop, which is forming the hepatico-jejunostomy.
Anastomia.
All right,
Yes,
good case.
yes, sir.
Too tough.
No,
So these are just so this is just an interaction between you and me. You may or may not get to see these cases, but the same thing may happen with the gastrojejunostomy. The same you will at some point of time see surgical complications related to the holes that they make in the mesentery. All right. So
yes, sir.
when you when you are seeing surgical interventions in the abdomen, particularly when they are crossing compartments and you are getting twists or you're getting two narrowings together with signs of ischemia, consider the fact that you may be dealing with an internal herniation or an internal uh, widening of the holes that they have made, and too many things have gone through. All right.
Yes.
Okay. Who's next? So this one is
Akash.
mainly an arterial. This is a spotter for you. All right. So should I make it coronal? Okay, I'll make it. All I want you to do is look at the arteries and tell me what
Dissections.
is the diagnosis. All right. You look at the axials first. I'm going to show you the axials first. That's the aorta. All right. That's the celiac axis.
Yes.
That's the common hepatic. That's the right hepatic. Okay. I hope these are projecting well. That's the superior mesenteric artery.
Yes.
Okay. And then that's the celiac. This one. And I'll lift this for you. Those are the renals. And then we have this structure here.
Thrombosed aneurysm.
Okay. So this patient came to us with acute pain abdomen. So this is a thrombosed aneurysm. All right. Anything else? Do you know of a entity which causes this? So what all are you seeing? Just tell me your findings. We'll reach the diagnosis later. One is a thrombosed aneurysm.
Yes.
Anything else? Is the aorta fine?
Yes.
Yeah. Is the celiac axis fine?
No.
No.
Flap is there.
Good. And along with the flap, is there an irregularity also of the artery?
Yes.
Yes. Okay. Then let's look at the renals. Renals can be plus minus. There may be a difference of opinion. I can live with that. But do you think this is a good renal artery?
No. No. Irregularity of wall is.
Then do you think this is a good renal artery?
No.
No. Right. So
String of pearl appearance.
sorry. Yeah.
String of pearl appearance.
Okay. But how does that sit in with this? So string of pearls appearance would be one of the diagnoses which you want to rule out, which occurs in what entity?
fibromuscular dysplasia.
FMD. So there are different types of FMD, adventitial, cystic, etc., etc. At any rate, we will not get into FMD because this is another entity I wanted to know about, which is very common. It is many times reported as a dissection, and sometimes you see thickening over here. And does anybody know what this entity is? Let me see. Not FMD, not FMD, and somebody has it. Yes. So this is something called segmental arterial mediolysis, or SAM. So this is, as the name suggests, an arterial anomaly in which there is an issue with the media, and there are cystic spaces formed in the media of the tunica media, which causes these characteristic areas of dissection. You can get bleeds also in these patients, which are a little rare in my opinion. These patients generally come with severe abdominal pain, and they have a relapsing and remitting course. The most commonly involved arteries are the celiac axis and the superior mesenteric artery. But like in our case, you can have involvement of the renal arteries also, and you can have involvement of the iliac vessels. So the most common involvements I have seen are celiac, SMA, renal arteries, and the iliacs. You can also have SAM in the cranial or extracranial vessels. The thing with SAM is there is a lot of controversy as to what to do with it. There is no treatment for it as such. You have to differentiate it from an acquired, you have to differentiate it from basically an inflammatory arteriopathy like that associated with GPA, which I've rarely seen causing abdominal aneurysms. And you have the other differential diagnosis is FMD. The other two differentials would be congenital disorders causing multiple arterial aneurysms, such as uh, Lloyd-Dietz syndrome and Ehlers-Danlos syndrome. Okay, there is an article by Sanjeeva Kalwa. I can't go into the theoretical aspects, but just remember, when you see a characteristic dissection in the celiac or SMA with periarterial thickening, this is the entity you have to think of. This is called segmental arterial mediolysis. Okay, and the patient comes with pain. So this is again a spotter. Whose turn?
Mine, sir.
Mine. That's it. Okay. I can't see you basically. I'm just looking at the screen.
Yeah.
So, all right. So this is a patient. She underwent a Whipple's 2 weeks ago. It's just a nice finding, which is why I wanted you to see the case. So can you see anything wrong? Is this a normal post-Whipple's appearance? Do you think?
No, sir. Stomach is overdistended.
That's correct. That's the major issue. This patient was vomiting, vomiting, vomiting. Look at where the stomach has reached, right?
Yes.
Then we thought there is too much muck, so we tried to decompress the stomach and scan again. So we put in a Riles tube and we scanned again. We did a plain scan first. We thought, okay, maybe we can live with this amount of distension, and then we gave contrast. Okay, so we gave contrast. So can you see any reason for the stomach to be distended?
Into susception
Of
duodenum into stomach, into the pylorus.
So the duodenum is somewhere here.
Jejunum into the pylorus.
What? Not the pylorus is also not there because this is post-operatively.
Okay, right.
So what part of the jejunum? So what are the parts of a Whipple's procedure? What all do you do?
We remove pancreas.
Yes, head of the pancreas.
Head of the pancreas. We do hepatic
what do you do with the stomach? Because you are removing the pancreas, then you remove the second part of the duodenum, right?
Yes.
So now you have to make an outflow of the food from the stomach into the small bowel. So what will you do?
Partial gastrectomy is done.
Yes. Then what? After that, what do you do?
Gastrojejunostomy.
Correct, correct. So what has happened here? one of the loops which is forming the gastrojejunostomy has herniated through the gastrojejunostomy into the stomach and caused gastric outlet obstruction. Is this the afferent loop or efferent loop? You know there will be two loops, right?
Yes, sir.
So will this be the afferent loop or efferent loop? So afferent is bring stuff in or take stuff out.
Afferent is the one which brings stuff in.
Correct. So do you think there is a problem with getting stuff out?
Yes, sir.
Yes. So this would be the
Efferent loop.
efferent loop. That's correct. So even without kind of banging your head on trying to, so this is one part, right? So this is anastomosed over here, then the loop goes over there. So this is a retrograde jejunogastric into susception, causing severe gastric outlet. Yep. Great. Fantastic. Absolutely right. This is another spotter for you. This is a young guy. Severe pain abdomen. Let me.
Diffuse thickening of colon is noted.
Then there is diffuse thickening of the colon. There is ascites, right? Yes. What is the diagnosis? This is
Pseudomembranous.
Why? So if you were to sit in the exam and your examiner asks you, why is this not ulcerative colitis? First of all, you know what this sign is?
Audience.
So this is a case of pseudomembranous colitis, right? But the main challenge when you get something like this is to try and differentiate an infectious colitis from an inflammatory colitis. And then if you've seen the infectious colitis, you have to try and slot it into something. So there are lots of articles regarding how to differentiate them. Like right-sided involvement is more common in amoebic. It's more common in salmonella, right? But we have seen amoebic everywhere in the colon. In Indians, we get amoebic even sometimes in the rectosigmoid without involvement of anything else. This is what is known as the empty bowel sign, right? The empty bowel sign is supposed to be more commonly associated with infective colitis rather than an inflammatory colitis. There is no air, there is no feces, there is nothing. The other thing is ascites is more commonly associated with an infective or inflammation with an infective colitis or an inflammatory colitis rather than a ulcerative colitis or Crohn's disease. Okay, so there is an article in AJR, you can go and look it up and how to differentiate the various types of colitis. In this case, this is, you're right, the accordion sign, and this is a classic case of pseudomembranous colitis, right? Happy with this one? This was simple, right? I can't hear anything.
Yes, sir.
Okay, nice. So far, is this good, or you want me to go on to something simpler, or you are enjoying it? You're happy?
Yes, sir. Yeah, enjoying it.
You're enjoying it? Great. Fine. So here is a guy. He was living happily in his house. He was 72 years old. And he started having severe pain abdomen. And then he landed up with us. If you want to look at any other phase, let me know. We have a whole multi-phase study for this guy. Okay. And severe pain abdomen. What's happening here? And here is the venous phase here. Another relatively simple case for whoever has drawn it. So what is this? Spotter? Sorry.
Carcinoid.
So why has he got pain?
Due to serotonin release.
So he
Uh,
okay. Then due to serotonin release,
it would in turn cause diarrhea,
but he's got pain, na?
cramp, and cramps.
But he's got pain. Okay. But he's not got,
Okay.
he's got severe unremitting pain. Do you see anything in the scan which would cause severe unremitting pain?
There seems to be a closed loop obstruction.
Okay. When do you say it's closed loop?
The same part of the bowel is involved.
Basically, two parts of the bowel are involved. There are two parts of obstruction. Usually they are close to each other. Not always, but usually. Okay. Anything to say about whether the loops are thickened, thin, normal? These are some loops here.
The bowel loops appears to be edematous.
And these are some loops here. Okay. So
yes.
Are these the same? Is this loop the same as this loop?
No, sir.
No. What is happening?
There's probably ischemia which is causing the bowel loops to be edematous.
Yes, because the loops are dark, they are thick. When you get ischemia with bowel loop thickening, is it a venous ischemia or more commonly an arterial ischemia?
It's a venous ischemia.
Most of the time it's a venous ischemia. Sometimes you can get thickening in arterial ischemia with reflow, but most of the time it will be a venous ischemia. So did you look at the veins?
The lesion seems to be in close proximity to SMV probably.
So can you see what is happening to the lumen? So let's try and trace the superior mesenteric vein. Here it is. Okay, I'm going down. You're going down. Here is the SMV. Here, there's something happening there. Okay, there's something happening there.
Seems to be like a chronic thrombus.
So basically, can you see that the tumor also has calcifications?
Yes.
Don't say chronic thrombus when you're seeing an acute ischemia, right?
Okay, right.
These are pitfalls we want to avoid in the exams. We don't want to say two discrepant statements on the same patient. You are saying acute ischemia, you don't want to say a chronic thrombosis. Then you have to, in your mind, figure out, am I wrong about the acute ischemia or am I wrong about the chronic thrombosis? So what has happened is basically the tumor has infiltrated into the superior mesenteric vein. It must have gone slowly, but at this point of time, now it has totally closed the superior mesenteric vein. And because it is a cicatrizing tumor, the vein has become small in size. Okay.
Yes.
You would be right to say chronic thrombosis because the vein is small in size and has calcifications. Normally, that would be a chronic thrombus. Okay.
Yes.
But in this case, because we are dealing with a lesion which causes a severe desmoplasia, that rule does not hold true.
Okay.
All right. Great. So there must be there may have been a primary somewhere in one of these loops. Most of the time, there is a small primary there with a mesenteric component. So this was a mesenteric carcinoid which had closed off the superior mesenteric vein and then caused acute venous
ischemia.
And always look at the enhancement of the bowel. See how dark this is.
Yes.
Yeah. All right. Moving on. This is an MRI of the same patient. We are doing CT today. All right.
Yes.
Okay. So here we have a 12-year-old boy who had severe pain in the abdomen. It was localized to the lower abdomen. Okay, but it was almost to the midline. He could not really All right. So another spotter, another easy case for someone. Anything we can see here?
Lesion is not in the left pelvic region.
Okay. What are you seeing?
Overlook.
Sorry, I'm losing you there. Hello?
Like appendicitis.
Sorry?
Bowel loop is infected bowel loops.
Infected bowel loop. So all the bowel loop is nicely opacified with contrast. Why would one loop be unopecified?
Meckel's diverticulum.
Should be touching the bowel somewhere. Usually on the right side,
Yes.
right? No air, which is okay, it may be twisted, but very low down. Some fat
Like appendicitis.
should be touching the large bowel somewhere.
Yes.
Large bowel is nowhere near it. Okay. Twelve-year-old boy,
Undescended testis.
undescended testis. I'm showing it to you. Then what about it? Undescended testis.
Torsion.
Yeah. So this is a torsion and undescended testis. Okay. So it's you just have to keep your eyes open for normal structures as well. So one of the things you have to do is not miss out in your eagerness. Again, satisfaction of search. Process is very important, right? In radiology, everywhere. Even when you think you've seen the abnormality, finish looking at the rest of the scan, go back to your abnormality, and then try and qualify it, especially in patients who have acute issues. Because they may have, you may get an answer as to what is happening. And as you can see here, there is no spermatic cord here.
Yes.
And no testis on the left side. So this generally on an undescended testis would either occur very early in age or it would occur with a tumor in this patient who had neither. Although this patient did have infarction in the testis with the torsion, this occurred at the age of 12 years. All right.
Yes.
Did you enjoy that?
Yes, sir.
I really enjoy my work. I hope you guys do too, because if you like, radiology is the best branch you could have ever picked in your life. I think we're lucky we get to see everything and we get to kind of decide or weigh in a lot on patient management, and we get to see our patients as well as the consultants. Okay. That's plain. That's contrast.
Yes.
That's contrast. What's that?
Bowel loop appears to be thickened.
Yes.
Is it Crohn's?
See, you never jump to the diagnosis like this. Why do you think it's Crohn's? Okay, tell me.
There are skip lesions noted.
Where? Which is the skip lesion? This is the. Let me trace the power for you. Okay. Let's see.
Okay.
There we are. So this is the DJ flexure. Then
Yes,
we are the bowel. We are going ahead. Okay, it turns, then it turns, then it turns, and it goes down. Then it goes down, and then
okay.
there is the skip lesion. Needless to say, this patient had acute pain abdomen. Unless otherwise specified, everybody has acute pain abdomen in this discussion.
Okay.
Let's look at. Okay. No, where is the gallstone?
Okay.
Okay.
In the jejunal.
Yes, there. Okay, so no, this is not a gallstone. First of all, is this a plain scan or a contrast scan?
It's a contrast scan.
The contrast scan, where is the contrast?
The one towards left is contrast.
No. Can you see my arrow?
Okay, that's the plane scan.
So what is happening to the bowel loop? First of all, which loops are we dealing with?
Vaginal loops.
Are they normal? Are they dilated? Are they thickened?
They are dilated and thickened.
They are dilated and they are thickened. Is the mesentery fine? You never describe the bowel without looking at the mesentery. Okay, they are literally the same thing.
Okay.
Is the mesentery fine?
No.
No, it's not fine. There's a lot of
No.
smudging.
Yeah.
Is the bowel dark? Is it normal? Does it have air in its lumen? Does it have air in the wall?
No, sir. Not in the wall. It's in the lumen.
But does it look normal? Does it look bright?
Yes, sir. It's not normal.
So does it look brighter or darker than normal bowel? Would you expect bowel to be same density as liver and brighter than the kidney? That's
No,
what
sir.
you can make out it's very bright, right?
Yes, sir.
Can you now make out actually that it's bright?
Yes, sir. It's bright.
Yeah. So now you have to tell me what is the cause of a diffusely. So how do you classify bowel thickening? If I say there is focal thickening, what do I mean by that?
Less than
Less than
1
5.
centimeter. 5 mm.
0 to 5 centimeters. Okay. There is focal. Then there is 5 to 40 segmental.
Segment.
And more than 40 is diffuse. So this is segmental thickening. Okay?
Yes.
If you see a segmentally thickened bowel loop, which is appearing bright, what is the first thing you think of?
Hemorrhagic.
Yes. So what is in your practice, what is the most common cause of hemorrhage into the wall of the bowel? It is almost always a superior mesenteric vein thrombosis. Okay. In this patient, it is not that. In this patient, there is what is called as an intramural bleed in the lumen, in the wall of the bowel. Okay. This patient has like you can get intracerebral bleeds. You guys must have seen tons of those, right?
Yes, sir.
You can also get a bleed in the wall of the bowel.
Okay.
This is an intramural bleed into the wall of the jejunum. The other thing is, if you are ever posted at night and you look at this, you find this bright bowel, always look at the superior mesenteric vein. Even on the plane scan, if it is an acute thrombosis, the superior mesenteric vein will appear bright. All right?
Yes.
So what is the treatment for this? No treatment is required if you make the correct diagnosis. But if you do not make the correct diagnosis, then this patient will have all sorts of things like laparoscopy, surgery, double balloon enteroscopy, depending on how badly we are off the mark. So that is why I tell you that, we decide. If we are good at a job, we make such a big difference in the life of our patients that it's amazing. Nobody realizes it, not even the treating clinician, not the patient. But if you were to call this something like Crohn's, this patient would have things like double balloon enteroscopy or a capsule endoscopy and such like things, okay?
Yes.
This is an intramural hematoma, and this patient actually was on double anticoagulants, all right? What is this? Actually, I had to, okay. Whose turn? Another spotter. So, Amit, will you let me know when I'm supposed to stop?
Okay, but you can continue now. It's 7:45.
All right. So, whose turn?
Akash.
Akash, patient has got severe pain abdomen, as usual. Throughout this lecture, everybody has severe pain abdomen. Okay.
So ectopic kidney is there in transplanted kidney in the itilac fossa.
Not ectopic, it's transplanted kidney.
Yes.
You have two kidneys here.
Yes.
Great. You have transplant kidney in the right Ilia
Yes.
fossa, half our battle is 1. Now, anything abnormal you can see? Let me... See, I was not going to show you ureteric alkali and cholecystitis in this talk, right? Otherwise, Akshay would say, useless fellow. Why will I call him? Little bit interesting.
Yes.
So far, interesting?
Yes, sir.
Very good. Good answer. So, what's going on here? I'm showing you the abnormality. If you want
Yes,
me
sir.
to scroll up, scroll down, show you sagittals, coronals, tell me, I'll keep doing it for you.
Small collection is noted along the bowl.
This one?
Yes, sir.
Okay. So, where is this collection going? It goes here, then I'm coming back, and it goes here. Then I'll show it to you in the coronals. This is what we are calling a collection. All right. This is very well defined. It goes
Yes.
like this, then it goes back, and it goes here. What is this?
IC junction.
This is the cecum, base of the cecum. This is the IC junction. Can you see the IC junction now?
Yes, yes.
So this is the base of the cecum. So any ideas as to what's happening? So how do you identify the cecum? On CT, how do I say this is the cecum?
Postural patterns, IC junction, and then appendix.
What above the IC junction, below the IC junction?
Below the IC junction.
Below the IC. So this is the cecum. And then what is the second thing you said?
Appendix.
Appendix. Where is the appendix here?
Mucocele. Postural appendix.
So a mucocele would not go so distally. It's just in the center. This and going ahead. You could call it. Mucocele would have more mucus in it, right? It's really thick. So what is it?
Abscess.
Abscess. All right. But then, have you seen an appendix abscess where the appendix has not ruptured?
No.
It hasn't ruptured, right? This has got some fluid, some soft tissue, a lot of thickening here. Put it together with the other finding you have.
Renal transplant.
Yeah. So what are the
Malignancy, lymphomas.
So yes. So basically, this is on the spectrum of PTLDs. This is an PTLD of the appendix or a lymphoma of the appendix. I will accept both. Right.
Yes.
So 2 and 2 together, and of course it is humongously inflamed. You can see the mesentery around it is inflamed. Don't ignore the mesentery. Don't neglect the inflammation around it. All right. You focused again on the mass or the thickening, but you can even see little pockets of fluid. You can see a lot of haziness and standing, some dilated bowel loops, telling you this is a very acute condition.
Yes.
All right. Good one?
Yes, sir.
Good answer again. Anyway, somehow I really enjoy these things where you can put 2 and 2 together and get an answer at the end. Again, a spotter. This one is really a spotter. So this is a young female. Okay. She's come with what?
The ovaries appear bulky and in the midline.
Both of them?
The left ovary is bulky and in the midline. Probably due to ovarian torsion.
Okay. How did you decide there is torsion? This ovary is enhancing here or not enhancing?
Yeah, it's enhancing.
Enhancing?
It's a plain scan.
Oh, good. I was waiting for that. My favorite.
Hemorrhage probably because you can see.
Exactly. So there is hemorrhagic infarction of the ovary. So never, so the moral of this is never neglect your plain scans. Okay, so you might get confused thinking this is enhancing, but it is large. It should be a torsion, but why is it enhancing so well? So it is actually not enhancing. It has what? What has happened to it? There is a hemorrhagic infarction of the ovary. So this is an ovarian torsion in a young girl. Okay, so good. That went by fast. Here is another spotter.
Yes.
I need the diagnosis.
Emphysematous pyelonephritis.
All right. Specifically, why do you think emphysematous pyelonephritis is fine? Why is all this black stuff?
Air foci.
Yeah, but why is it looking? I mean, can you see the kidney enhancing?
No, sir. Comparison to left, it is less enhanced.
What is this? Comparison to left also. What is this?
Renal vein thrombosis. Collection. Infarctions.
Have you seen lot? Yeah, there is an infarction. Correct. Have you seen emphysematous pyelonephritis?
Yes, sir.
Most of the time, the creat will be very high, right? We will not give, but and they'll be diabetic.
Yes, sir.
Even then, I don't know. I don't recall seeing a lot of contrast, but I've never seen a kidney which does not show any enhancement at all in EPN. Have you? I'm just
Not
asking. Normally, you would not see it.
Yes.
Right? And then there is a clue here.
It's thrombosis.
Yeah, there's a thrombus here in the renal vein as well, going into the IVC. So
RCC.
no. You have to decide in your mind: am I dealing with a neoplasm or am I dealing with an infection or inflammation? When you look at the kidney like this, do you think it is a neoplasm?
No, sir.
So don't. So we are not going to fire off wild guesses left, right, and center because somebody says no. We are going to stick to our basic premise and work around that. It's an emphysematous pyelonephritis. Yes, I'm looking for the organism which gives you this very characteristic appearance. You may or may not get air, but you will get solid renal infarctions. And you've seen a lot of this in COVID, but not in the abdomen as much as you have in the head neck phase. Okay, this is mucor. So mucor, when you are getting non-enhancing kidneys, you can even have bilateral non-enhancing kidneys. When you have absolutely non-enhancing kidneys, non-enhancing spleen, infarcts in the liver, venous uh, thrombosis where you are seeing extraluminal things extending into the veins, always think of mucor. And for some reason, especially around the bowel also, they tend to have this weird collection. One side will have a crescentic collection. This is just mucormycosis.
Yes.
See, what do we have here? Okay. This is not pain, so we will not take this. We will only take pain. Neither was this woman pain, I think, although that was a good case. We'll come back to it if we have time. Okay, so this is another spotter from the exam point of view for you guys. What is this?
We can't see the case.
You can't see it?
Yes.
Now we can see.
Give you a coronal as well. Or should I make this coronal? I'll make this coronal. Here. And we'll make this mean. What is this?
There's a filling defect in the stomach, probably due to foreign body, with calcification within, probably likely due to trichobezoar.
So trichobezoars tend to have what inside them? They can have trapped here. So do you see a lot of air? And
Yes, sir.
you get such a small trichobezoar not going anywhere, quietly sitting there. Normally they'll have trailing hair here and there, right?
Yes, sir.
So have we looked at everything else? The liver is fine. Gallbladder is fine. You can stop me if I'm wrong. Pancreas seems okay. Spleen seems okay. Any of these structures, kidneys, any of these structures seem abnormal to you? What is the appearance of this? Is it lamellated? Is it variegated? Is it round? So trichobezoar generally never have this
Is it a gastric dermoid?
Gastric dermoid should have fat in it. You can see what looks like fat, but then it should be attached to the wall. Let me see if we have something else for you. Oh, it's moved. Now what? Now I'm giving you the answer. So can you see the gallbladder?
Okay.
This is the duodenum.
Yes.
This is the gallbladder fossa. Can you see the gallbladder anywhere?
No, sir.
Look at this one. Can you see a little focus of air there?
Yes, sir.
Okay. What's the diagnosis? This would be, does this look like a calculus to you? A large gallbladder calculus?
Yes, sir. There seems to be some kind of fistula.
So what is it called? If you have gastric outlets obstruction due to this stone, there is a name for it. What's it called? I leave it to the participants to put in the chat box. What's it called? What? Yes, it's called Boveret syndrome. Yeah. This was a nice one.
Yes, sir.
Good answer again. I would love to have you working with me. You say yes, sir, to me all the time. Lots of people don't. Here is another one for you. This is intestinal obstruction. And patient came with pain. As usual. Pain everywhere.
Small bowel sign is
correct. What is small bowel feces sign?
Sir, it's an indicator of small bowel obstruction where feces accumulated at the distal end of.
Yes. So basically, what looks like fecal material, which should normally be in the large bowel, is seen in the small bowel, and it is indicative of what?
Small bowel obstruction.
No, it is indicative generally of that you are very near the site of the obstruction.
Yes.
So look at the small bowel feces sign to kind of find
localized.
Yes. Can you see anything else here? Where is my audience in the chat box? Somebody is close to it. Okay. Can you see something? Okay, let's look at this air pocket. Does it look linear to you?
Yes, sir.
Okay. Can you see something here? Inside the lumen of, can you see what this is?
Hyperdense areas.
Hypodense? Hyperdense. What is this long stuff inside? Can you see this?
Appendix?
No. I'm showing you something in the lumen of the bowel. See? This is the wall of the bowel. This is the lumen. What is this? What
Worms.
Yeah. So basically, this patient had tons of ascaris.
Yes.
And they were all bunched up here, and this patient had small bowel obstruction due to ascaris. Okay. And you can see the ascaris here. Let me see if I can make this minimum and make this a little bigger. So can you see the worm? Can you see this worm here?
Yes, sir.
Yes, sir.
These were all worms in the lumen of the bowel, and they had caused obstruction where you could see the small bowel feces sign. Okay, this is a fairly simple one. Let's go to the next one. This is a GI bleed. Again, no pain. We want pain. Okay. Here. What's happening here? This is not a very exciting diagnosis, but the findings look very alarming. Okay, I'll show you what happened basically. So this patient has a big air collection here.
Yes, sir.
And what you can see is the gallbladder is in relation to the air collection.
Is it emphysematous cholecystitis?
So there is air in the gallbladder, but most of the gallbladder doesn't have air in it. So there was a gangrenous cholecystitis which perforated into the colon, and then the colon perforated, and all this fecal material came out. Okay, and there is free air also.
Yes.
There's an emphysematous cholecystitis perforating into the colon. And this is what I meant when I was asking you. So this is, I should have shown you these two cases together. So in this patient, there was thickening, but there is, see, you can see the thickening.
Yes, sir.
Right? And you can see the hypodensity, but what you can also see is a SMV thrombosis. Whenever you are looking at thickened small bowel loops, which are enhancing less, but may have hemorrhage in them, always look for your superior mesenteric vein. All right.
Right.
All right. I think we'll make this our last case. Patient did come with pain and had drop in hemoglobin. This is the plain scan. All right. This is your arterial. And this is your venous. So what's happening here? Sorry?
Aneurysm.
Of?
Hepatic artery.
Hepatic artery. Why? Why is there IHBF? And what is this? Where is this blood? Inside the lumen of an artery? It's arising from this artery, but is it in the artery itself? Is it an aneurysm? Is it a pseudoaneurysm?
Yeah, it's a pseudoaneurysm. It's not in the lumen of the artery.
It is in the lumen of?
GB.
Yes, correct. And what has happened to the wall of the GB?
Seems to be perforated.
So basically there is an acute cholecystitis with a perforated gallbladder, and the inflammation has caused erosion into the cholecystic or right hepatic artery, and all this is an pseudoaneurysm inside the lumen of the gallbladder. All right. So Dr. Amit, should we finish?
Yes, that sounds good. We have had some really terrific cases.
Okay. I'm just trying to see if I can give you a good last one. But unfortunately, I'm not sure what I'm looking at. Although it must be pain somewhere. Just hang on. Oh, not this one. So I guess we shall say goodbye over here. All right. So I'll just tell you, this looked like an appendicitis, but there was a lot of enhancement here. This one was a carcinoid of the appendix presenting as acute appendicitis, right? And I think we will end over there. Thank you very much, guys.
Thank you, sir.
Yeah, thanks a lot. And we shall end our screen share, I guess.
Thank you, Dr. Samarjeet. Those were some really excellent cases, complicated but lots to learn from. And there are a couple of questions in the Q&A box. Perhaps you can. I believe you answered most during the presentations and discussions, but you can perhaps address a few of these.
Sometimes proximal jejunal loops are seen to the right of midline with normal DJ flexure. As long as DJ flexure is on the left of the left margin of the vertebral body, we don't call it malrotation. Large fluid collection in this case is abscess. I'm not sure which case this was. How to see on CT which part removed of pancreas? Always the head is removed in Whipple's. Otherwise, it is called a distal pancreatectomy. All right, subacute bowel is a terminology we generally actually is a good question. Even I don't know, but that is what the surgeons call it. We write acute bowel obstruction or bowel obstruction. I don't really call it subacute or acute. Intramural hematoma of the bowel diagnosis was anticoagulant related hemorrhage. So much inflammation in PTLD lymphoma is because there was an appendicitis associated with the PTLD. So the PTLD caused an appendicitis, and that appendicitis was what brought the PTLD to light. Obturator nodes site on CT. That's an ectopic. Obturator nodes are between the internal and external iliac veins. I think part of the external iliac group. Uterosacral and cardinal ligaments on CT. I will need I don't remember the cardinal ligaments. Uterosacral also not very well seen as far as I know. Root of the mesentery, when to say involved. Root of the mesentery is the part where the SMA is coming out of the aorta and going into the small bowel mesentery. Involved means in tumor is when the tumor is near the origin of the SMA. How to differentiate with appendicular abscess in lymphoma case, as there is so much inflammation present? It can be difficult, but you basically have to just kind of answer why would there be an abscess along a tubular structure. Right? So that would be very unusual. The abscess should be round and should have actually ruptured the appendix. Should we suggest causative organism in emphysematous pyelonephritis? No. But you can suggest mucor if you see it, because every day is important in the management of mucor. Adrenal CT protocol, how to interpret lesion, that's a whole talk in itself. Please show the transverse mesocolon once. So the transverse mesocolon is when you go anteriorly from the pancreas, and basically the easiest way is you look at where is the middle colic artery running, and that is the area of the transverse mesocolon and the veins, and generally they will go back towards an area anterior to the pancreas. Worm versus normal bowel loops, I don't know how to answer that. What's your protocol for CT abdomen? Depends on what is the indication for CT abdomen. How do you differentiate afferent versus efferent loop? First of all, you should be able to see it on the coronals. But if it was an afferent loop obstruction, the stomach would not be dilated. Only an outflow obstruction would cause a dilatation of the stomach. So even if you don't know the answer, if there is an obstruction, it would be an efferent loop obstruction. Small intestinal bacterial overgrowth. I have no idea how to differentiate, but the thing is, Why would the bowel loops be dilated to a particular transition point in small intestinal bacterial overgrowth? Is there any job vacancy or fellowship to learn under me? Not yet, but you have my email, or you can ask Dr. Akshay. And last case about emphysematous cholecystitis eroding into the artery. No, the emphysematous cholecystitis not eroding the artery. The artery was eroded by the gangrenous cholecystitis. So when there is inflammation, so the theoretical aspect is that the inflammation causes avascular necrosis, which causes thrombosis of the vasa vasorum. The vasa vasorum die off, the artery then gets injured and forms a pseudoaneurysm. That is one of the causes. The other is that the pressure inside the gallbladder rises so much that it causes vascular infarction and causes a pseudoaneurysm. All right. Do you always do plain CT abdomen? Yes, I always like to do a plain CT abdomen because I feel, except in certain cases, that it adds a lot of value. Is that all right?
Yes, that's perfect.
Okay.
Thank you again, Dr. Samarjeet,